Jenny, nice to meet you. No videos, but I'm gonna probably walk because I don't know if I can see my slides. No worries. I think we should go ahead and get started. It's about 5 minutes after the hour. I know some people will be wandering in because of the early hour, so I thank you all for being here. I'm trying to find my voice. Excuse me. For those of you who don't know me, my name is Lisa Christopher-Stine, Dr. Lisa, Dr. Christopher. I answer to a lot of things. I'm the director of the Johns Hopkins Myositis Center, and at the end of my talk, I'll show you a little bit about our center in Baltimore. We started the center 9 years ago, and I've been watching this meeting really just progress, and I think it's sort of reached fever pitch this year, and I'm so thrilled to see all of you, to see the excitement here, to see the energy around a disease that I spend my life thinking about, treating, researching, and it's been a great genesis over time of watching the interest from pharma and from others. So I thank you for being here. Those of you who may have the syndrome, think you might have the syndrome, I'm going to help you try to pronounce the syndrome and tell you a little bit about it. So I will tell you that when I spoke to Teresa, I said, well, I'll be leaving in the afternoon on Saturday, so just can you make sure I just speak a little earlier? I want to tell you, I did not request this time period. Just saying, I too like to sleep, so I'll try to keep you with me. So breakfast starts at 8 a.m., but Teresa tells me we have up until around 8:30 if need be. I'm going to start the talk and give you some background. I'm actually going to be pretty technical and tell you things you may have not heard before because we don't really get the chance as physicians to tell you details like this during an office visit. So I'll tell you some technical information, some clinical information, and then mostly what I'd like to try to do, and those of you who know me know I have the gift of gab. I'll also try to slow down my speech. At the end, I think it's important to have a Q&A, and I'll try to repeat the question. The reason I say it is that a lot of people in the room may have the same question you have, so this is your time to ask me, and I'll do my best to answer. I'll also tell you that while we spend our time researching, rare diseases are hard to find answers to, and so sometimes there really are no answers. Specifically when it comes to therapy, which is what most people want to know about, the data is really scant. So I can tell you from experience, but I can't always tell you from trials because there are so few of them, difficult to fund, difficult to get patients into them. Okay? So with that, we'll go here. So what is this thing? These are the clinical features. You don't have to have all of them, and I'll tell you about how we try to diagnose. But in general, you have to have myositis, but I'm here to tell you, you don't have to have myositis. It turns out that you can have lung disease with very, very minimal to no muscle disease, which made us rethink the idea that this is actually always a myositis. To be honest, those of you who have the JO1 antibody most likely do have muscle involvement, but some of you with the rarer antibodies like PL7 and PL12, which I'll talk about, may mostly have lung involvement. So we've seen that the syndrome is not even the same depending on the antibody that you have. Can you all hear me okay? Okay. So in addition to myositis, which you see on the right of that slide, that's a muscle biopsy and an MRI, which I'll show you details of in a moment. Most people also, or can, have interstitial lung disease to some extent, either severe, like you see on the left bottom there, Raynaud's phenomenon, mechanics hands, fever that's unexplained, so not fever because of drug fever or fever because of an illness, but fevers that just come and go that you can't quite explain, and you eventually realize it's part of the illness itself. And then generally, a non-erosive arthritis, an arthritis that you don't see erosions on if you look at an x-ray of the hands or feet. Okay, so the antisynthetase syndrome is a constellation of clinical features in the presence of a specific autoantibody. Jo-1 is the prototype, and I'll take you through what this means. As I told you, patients may not express all of the features of the antisynthetase syndrome, but usually express at least one of these: myositis, ILD, interstitial lung disease, ILD, or an inflammatory polyarthritis. So generally one of them, sometimes all of them, and then the antibody, and then sometimes those other features like fever, Raynaud's phenomenon, and mechanics hands. It's an autoimmune disease that targets a self-protein of the immune system, and that self-protein is one of 8 amino acid enzymes. An enzyme ends in the word ase, so a synthetase is an enzyme. And I told you that Jo-1 is the most prominent, it's the most common. The protein that targets that self-protein in your body, it is called an autoantibody. So sometimes the immune system fails to recognize one or more of the normal constituents as self. We have an idea of self as we call tolerance. We understand what self tissue looks like, and we don't react against ourselves. We react against foreign invaders. But that, when you don't recognize self, leads to the production of a pathologic autoantibody, self-antibody, antibody against self, protein against self. Those antibodies then attack the body's own healthy cells, tissues, or organs, and generally cause inflammation and damage. I show this to you because when I started my career, we knew just a few autoantibodies, and people didn't even know the significance of them. At this point, I start my day seeing patients with my fellow, and I say, what is his or her autoantibody? Do we know the autoantibody? Why does that matter? It helps predict your clinical course. Not perfectly, but it gives me a roadmap of what I'll look for in your future. And trying to play chess, be ahead of it, I want to prevent it, not wait for it, those complications. So this disease is not hundreds and hundreds of years old. I sort of marvel at my cancer colleagues that have centuries and thousands of years and talk about the history of cancer. Some of you may have seen the amazing documentary recently on PBS about cancer. We're very young. In this disease, it was only described in the late 1800s for the first time ever, until they figured out even that it was 2 separate diseases, this idea of polymyositis and dermatomyositis. And by the way, I think over time, even those names may change. Both of those prototypical diseases can be seen within the antisynthetase syndrome, so you can have a rash of dermatomyositis, you can have the dermato or poly version of myositis in this syndrome. But then the antibody discovery really happens in the 1970s, so we're talking about 100 years later. And if you look at this crazy timeline, actually Jo-1 was first described in 1980. That is not too long ago. So we have not had a lot of time to really figure out these syndromes. And then there has been a plethora of autoantibodies on that screen over time, with a lot concentrated in just the last 7 years of my career while I headed the center at Hopkins. Do any other myositis antibodies potentially mimic the antisynthetase syndrome? So you've got mechanics hands, you have lung disease, you have Raynaud's phenomenon. Indeed, yes. There are 2 newer players, particularly anti-MDA5 and anti-PMSCL. These are antibodies that may, in fact, look like the antisynthetase syndrome. In the absence of time, I'm happy to talk about that afterwards if you want to know a little bit more about that. Because my talk is on the synthetase syndrome, I'm going to stick to that. But I'll tell you, we have this dictum in medicine that if it looks like a duck and it quacks like a duck, it's a duck. But this time, maybe it's not a duck. Okay, it's a swan. So what is this synthetase? I show you, this is actually protein machinery, and I hope you can, I can't project on both screens. Actually, maybe I'll project here, it's easier to see. So the synthetase, which is actually here, this is the protein that actually helps to hook all of the amino acids onto to make its protein. So the target of your immune system is this little enzyme that is in all of your nucleated cells. Pardon me. And why that's the target, some odd enzyme like this, we don't know. it doesn't affect the function of that enzyme as best we can tell. It doesn't affect your amino acids. It doesn't seem to affect the function of that enzyme. So that's the target, but that target really helps us say that you are likely to develop very specific clinical attributes, the ones that we started with on the slide. Okay. Now, stay with me. And actually, that's that. How do we detect these antibodies? Well, the first answer is there's a screen called an indirect immunofluorescence. I promise these are the two most technical slides, and after this will be much more clinical. But so your blood, or your serum, the serum part of your blood, is incubated with a human epithelial cell slide that contains hundreds of protein, and it actually looks like that. The patient's unbound serum is then washed off that, and the bound autoantibodies are incubated with specifically labeled fluorescents, these fluorescent conjugates, and the unbound reagent is then washed off. So we then look, or not we, but the folks that do this work, look under a microscope, and under the microscope, autoantibody samples will exhibit this apple green fluorescence, and it corresponds to the area of the cell where the antibody is bound in a pattern of fluorescence that's indicative of that self-protein, which we call an autoantigen, being present. So this is a broad screen. This doesn't tell you the exact antibody. I can't tell you from this that you have JO1, but what I can tell you is you probably don't have this. And this is what an ANA looks like. Those of you who have heard an anti-nuclear antibody test, an ANA. It's the hallmark of lupus. By no means if you have an ANA do you have lupus, but when we look for lupus, this is something we look to be associated. And an ANA merely is that fluorescence that shows us that that self-protein is somewhere in the nucleus of your cells, okay? So it's the nucleus of the cell. In fact, in the antisynthetase syndrome, oops, sorry, hello? Slow but sure, it's not that, it's this. And so I think that maybe not looking under a microscope a lot, you could still appreciate that the nucleus is actually dark, and what lights up is the part of the cell called the cytoplasm, so it's around the nucleus. So this is the first indication that you have an antibody that resides in the cytoplasm of your cell. It's not in the nucleus. So all of the antisynthetase antibodies reside here. So that's our first step. We say, they have a self-protein. It sits in the part around the cell called the cytoplasm. These are the names of those proteins: JO1, PL7, PL12, and very rare ones, EJ, OJ, and some of these actually aren't even tested for in the United States. ZO and HA, I don't believe actually even maybe are commercially available yet. The vast majority of you sitting in this room, if you're here for yourself or a loved one, most likely reside in the top 3. And what you can see on there is what I told you in the beginning. If you have JO1, you're likely to have a lot of the syndromic features. You'll have lung disease as well as muscle. We think we see probably less rash, but you can have the rash of dermatomyositis, or you can just have the muscle disease of polymyositis plus interstitial lung disease. In PL7 and PL12, most likely the lung is what dominates your clinical course. You may or may not have had clinical myositis. That tends to get better, but the lung persists, and we're not sure why. The way that we look for these antibodies in a lab is something called Immuno Precipitation. And just suffice it to say, again, that we take your blood and we look for very specific precipitation patterns in a gel to say, what do they weigh? What do they look like? And these are, in a lab, how people detect antibodies such as PL12 or JO1 based on their molecular weight and a standard reference gel to compare against. Okay? So this is the scientific background behind your syndrome. So these myositis-specific antibodies, MSA is a myositis-specific antibody. We have myositis-associated antibodies, but these antibodies are specific because we don't believe the general population walks around with one. A lot of people have a positive ANA walking around the universe, and we're not sure why. A lot of times we don't see any clinical significance, but if you have one of those antibodies on the right of the slide, most likely you do have one of the features of the antisynthetase syndrome, or you'll develop one. So of them, of the myositis-specific antibodies, the prevalence, as you can see, JO1 makes up about 20%, so it's a big amount. The other in here is what we've been discovering over the last decade. But the rarer ones like PL7 and PL12 make up a pretty small piece of the pie. If we look at it in patients who also have interstitial lung disease, so we drill down to those of you who have known ILD, it turns out that JO1 is the lion's share of those, 70%. And then, interestingly, there's other antisynthetase antibodies here, so that would be PL7, PL12, OJ, EJ. And now this 10, which actually says unknown on this slide, we are over time getting to know those antibodies, and they may be the ones like MDA5 and PMSCL, those other mimickers I told you that look like a duck that aren't quite the duck. They probably are those that reside in that 10%. Okay, so now I'm going to take you, I promise that's all the sciencey part of it, we're gonna look through the clinical part of it, which is why you're here. So let's look little by little and dissect out each of the features of the syndrome. So let's go this way. Myositis. This is what those of you and many of you in this room have had the experience of having to have a muscle biopsy. In that biopsy, this is a cross-section of one of your muscles, and here I think you can appreciate that the cells look the same, they're about the same shape, they look the same color, shape, size, and that tells me that's a normal muscle. If you have polymyositis, these are lymphocytes. These are these little purple cells that are inflammatory cells, and they are within the muscle cell. So doctors call that endomysial, within the muscle cell. In dermatomyositis, interestingly, the very first target is this guy, and that's a blood vessel. Dermatomyositis actually targets the vasculature and then spreads out to hit the muscle, and it's usually found perimysially, or outside of the individual muscle fascicles. So the first thing we look at under a microscope to say if you have poly or dermatomyositis is what do those lymphocytes look like? Where are they? And what do your muscle cells look like? I think you can also appreciate that these muscles aren't all the same size and shape. There's various size and shape, which suggests that that's a myopathy. That's something that's abnormal in muscle. And then you can even have, this actually should go up there with dermatomyositis, perivascular inflammation. Necrotizing myopathy on the bottom of the slide shows that it's not lymphocytes. I think you don't have to be a scientist to say what's missing. Those little purple cells aren't there because lymphocytes do not dominate that type of muscle biopsy. This is a necrotic muscle biopsy. Necrosis is cell death, and what it means is that there are some cells that are dying, some that are regenerating. We see regeneration, degeneration, and lack of an inflammatory cell infiltrates traditionally as lymphocytes. And all three of these can be seen under the microscope, usually not both kinds, usually have one or the other, within the antisynthetase syndrome. And exactly what that means for you, we're still trying to figure that out. I'm showing you just briefly what an MRI looks like. Those of you who have had an MRI, this shows you the various types of muscle damage. Some of this includes IBM, which is not part of this talk. On the left is a sequence in the MRI called a T1, and that's showing you the architecture of the muscle. So normal muscle has this nice dark characteristic, and the white part that you see around that is a normal thigh fat that we have. As we go down, I think you can see that in the lower slides, there is more fatty infiltration in those muscles. So over time, when a muscle atrophies and or becomes, when the muscle cells die, fat infiltrates and kind of fills in where there used to be muscle. Over here, the corollary to that, this is called a T2 or a stir image. That shows us, that's fat suppressed, so I think you can see it's almost like the photo negative of this one, where the fat is bright here, the fat is dark here, and everything that's bright in this muscle is water, it's fluid, it's what we think is usually correlating to inflammation. So this is a hot, inflammatory muscle. Sorry. Whoops. Let's go back. So as you know, weakness is the most common symptom. It's proximal weakness, the shoulders and the hip girdle usually. What about pain? I was taught that this is a painless disease, that myositis doesn't hurt. In fact, many of you have taught me, sitting in this room, I see faces who have taught me that this disease, in fact, can hurt. So you can have pain as part of it. I will tell you it's rare to have pain in isolation with no weakness, but some of you are weak, get better, the weakness gets better, and the pain persists. And I can't tell you why, but I'm very interested in learning that. What else do we see? We see elevations of what we call the CPK or CK, which is a muscle enzyme, aldolase, and some of you may have originally had elevated liver function tests, LFTs. And what a poor name that is, because these enzymes don't come only from the liver, they also come from skeletal muscle. So some of these may be elevated as well. Interstitial lung disease. ILD is not a single disease. It encompasses many, many different pathological processes. So the treatment can vary for each of those diseases. Interstitial lung disease is a group of lung disease that affect the interstitium, and that's the tissue and the space around the little air sacs or alveoli of the lungs. That's why it affects gas exchange. That's why oxygen has a difficult time coming through there, because the interface between blood vessels that carry oxygen and air sacs that carry air just can't meet because there's inflammatory cells between them, making that exchange difficult. With me? Those symptoms that are associated are often cough, shortness of breath, or even worse, none at all, and completely asymptomatic. And that's why we generally, when you're first diagnosed, ask to get a CT scan of your chest. If you haven't had one, you don't have to get serial CAT scans in general, but pulmonary function tests are a must. Serial PFTs, probably on the order of every 3 to 6 months. When you're initially diagnosed, I recommend them more often. As they stabilize, probably twice yearly. If you have a change in symptoms, get one then. Don't do them during an illness when you have a bronchitis or other reason that we think is probably not related to the underlying disease, but if you don't know, certainly we'll get them. And that's a way to follow your progress over time. We look for very specific indices on the pulmonary function test, including that gas exchange number called the DLCO, which is the way that carbon dioxide moves across the membrane of the lung. We're looking for that gas exchange number, and we're looking for the total lung capacity, or something called a TLC. We look at those and a couple other measures over time to make sure your lung is functioning the way we hope it will. Okay. So inflammatory arthritis. So inflammatory types of arthritis may include multiple joints. Most of the time in this syndrome, I'll tell you that most of you tell me what hurt are your hands and your wrists, your fingers, your wrists. The primary symptoms, of course, are pain and stiffness in the morning or after periods of rest or inactivity. So in patients with inflammatory arthritis, the period of morning stiffness is often greater than an hour. Many of you will say it just takes a while to get going. You need a shower. You need something to just sort of limber up. You get a gelling phenomenon. Swelling, redness, or warmth around the affected joints may be seen. And usually, as I told you in the beginning, it's what's called non-deforming. You don't see the deformities of rheumatoid arthritis, which fortunately these days we don't see that much anymore either with the advent of very good rheumatology drugs, rheumatic disease drugs. But in general, you don't see erosions on X-ray and you don't see deformities on to the eye. Could you have an overlap with rheumatoid arthritis? If you suffer with a lot of arthritis, I think the answer is yes. I actually added this slide as I spoke to a woman yesterday who I saw her hands and I thought, they look more unusual than I see. Her hands looked like they were beginning to deform, and we really don't see that a lot. So could you have a true overlap? And what is a true overlap? Well, it says that you have an additional antibody, which we call seropositive rheumatoid arthritis, which I'll show you in a moment. So I would have hand and feet x-rays, so hand and wrist, feet and ankle, at least once. If they're good and you're not developing any other symptoms, fine. But if you have had evidence of arthritis in your hands, at least yearly you should be following these x-rays. And you're going to look for erosions and joint deformities with your doctor. Have the rheumatoid factor and an antibody called a CCP, which stands for cyclic citrullinated protein. We're famous for having things that like nobody can pronounce. There's a rheumatoid factor and a CCP, or RF and CCP antibodies. I recommend they be checked in you if you've had a problem with arthritis. It looks very similar to rheumatoid arthritis, and it probably acts the same way, and it may suggest that you would do better with a drug targeting that type of arthritis. So things like we call a TNF inhibitor. Raynaud's phenomenon causes some of the areas of your body, which is usually your hands. Other people will see it on their nose, their ears. It's places that are a little bit far from the core of your body. So it tends to be hands, nose, ears, places that our body would not necessarily try to keep warm because it's important to keep our heart and our brain warm, but your fingers and nose, they're expendable to some extent. So we might see this in the cold or during a stressful time. This happens because small arteries that supply blood to your skin begin to narrow, but they narrow like a spasm. Most of the time they don't narrow permanently, some do. They limit blood circulation to your affected areas, and this idea of a vasospasm, a spasm in the blood vessel. This also is treatable. Mechanics hands. Neil Stahl, who I know, in 1979 described this idea of mechanics hands, and some of you are experts in the room. You've actually taught me a lot about this and how you care for it. This is what we call a hyperkeratotic, thick skin, this lots of keratin eruption on the ulnar aspect. The ulna is the bone that's on the pinky side. So the ulnar aspect of your thumb and the radial aspect, the one closer to your wrist on your thumb side, of the rest of the fingers. And desquamation, meaning that the skin is sloughing off. The presence of mechanics hands has been reported to be highly relevant in patients with collagen vascular diseases like the antisynthetase syndrome. You also can see it occasionally in something like lupus and another disease, which we didn't even talk about today, called mixed connective tissue disease, which also has some of the features of what you've seen here. But most often, mechanics hands are part of the antisynthetase syndrome. And they can be really difficult to treat. Pretty prednisone responsive, and as soon as you lower the prednisone, they come back out again. This is really a bear for me as a clinician to treat. Okay, what kind of questions do I get asked? Do I get asked at this conference? Do I get asked daily in my practice? Do I think about as a scientist and a physician, clinician? Is my mortality increased? Am I increased risk for cancer? So I've heard that myositis and cancer are associated, and you would be right. Up to 25% of patients with dermatomyositis get cancer, but I'm going to show you some data that while this affects the lungs, a lot of the time, this antibody appears to be somewhat protective. Can you still get cancer? Yes. Do we think there's an increased association other than the general population of just getting two things, you have cancer and this syndrome? No. So it appears to be, and I'll show you data that suggests that you're not at any increased risk from the general population for cancer if you have one of these antibodies. Not that you shouldn't look for it or do regular cancer screenings, because you can still get two things. What therapies are available? I think I told you in the beginning, that's the hardest question to answer because we don't have a lot of data, but I can tell you what we use. Do I have any non-pharmacological options? Is there a specific diet? I don't have a slide on diet, but I'll just mention one thing. I'll say two things. Those of you who know me know I may have quoted this statistic. How many hours of training did I have in medical school on diet and disease? How many hours? Not days, hours. 4 hours in 4 years. So when you ask me about what I do for your diet, it's everything that I have to read on my own to try to figure out what diet has to do with immunity. Where is all of the immune system, most of it housed? In your gut. Right? So finally, people are noticing that maybe what you eat has something to do with how you express autoimmune disease. Does what you eat cause autoimmune disease? Haven't seen it. I've tried. Everybody's tried to look at this stuff. Should you follow a specific diet? Maybe. There is this idea that there's an anti-inflammatory diet. I'm a little bit reticent to tell you that that works for everybody because you eliminate legumes, which are beans, and I don't think that beans are always bad for people. So what I would say about diet is that elimination diets, something like the Whole30, these are diets that take things out little by little. You take everything out and then you reintroduce it. So say, boy, is dairy a problem? Is gluten a problem? And gluten is not the enemy of all things autoimmune. But some people just don't feel good with gluten, even if they don't have celiac disease, the true gluten sensitivity. They have sensitivity even if they don't have the disease itself. So I recommend those kind of things, but there is no research to date that really has a good answer about diet. And part of that is also you are not little mice that I can put in a cage and make you sterile and feed you with a dropper. And as you know, I'm human, you're human. I could tell you to eat this certain diet, and it's hard to do that. So it's very difficult to actually follow patients and put them in randomized trials with one diet versus the other. It can be done, but it's very difficult, and the disease is rare. So I don't know if we'll have an answer on diet soon, but I do say Look for yourself, take your time to think about perhaps taking things out of your diet and then reintroducing them and seeing if it helps you. Are there other complications from medications I should be aware of? Maybe, so I'll go through some of those. The last thing, which I don't have on the slide, which is anecdotal, is that those of you that do have myositis, I've seen some of my patients tell me that when their vitamin D is repleted, when it's higher than preferably 30, but up to 50, they seem to have a little bit better muscle function. So I'm just gonna offer that out there again. This is not scientific, this is anecdotal, but make sure your vitamin D is checked. Most of America is vitamin D deficient because we really don't see the sun a lot. And after the age of 60, even if you're out in the sun, you really don't have enough of the subcutaneous, the tissue that converts vitamin D from the sun. So you can be out in the sun, which I don't recommend if you have dermatomyositis. That's another reason, right? We tell you to stay out of the sun and then tell you to get enough vitamin D, and you can't really usually get enough from dietary sources. So often that's something that you actually do have to supplement. So take a look at your vitamin D levels. They may or may not help you by supplementing them have better muscle function. So we're also going to look at that from a scientific standpoint, but for now, I can tell you it's anecdotal. So what about therapies? I'm going to give you, this is a laundry list, and I'll spend time speaking individually about therapy questions that you may have. So prednisone is the mainstay of therapy that we use. Prednisone, as you know, I always say it is fantastic in the short term, and it's pretty evil in the long term. Our goal is to try to get you down to as little or no prednisone as we can, because the side effects of that drug are pretty severe over time. When prednisone was first introduced, I believe in the 1950s, it revolutionized autoimmune disease. It went from, these diseases went from fatal diseases to treatable diseases. However, over time we realized that this was not the miracle drug that we needed because of all the long-term side effects. And I don't have to quote them for you, I'm happy to. But as you know, there are many. Acthar or ACTH gel is on label. That is a product that is on label as it was grandfathered in from many years ago. ACTH gel does have an FDA indication. Because of the expense of the drug, admittedly, I don't use it first line or higher. We are hoping, there are trials that have been done. There's some early observational studies, and we ourselves are hoping to look at this drug a little closer to see where exactly it should fit in. But it has steroid benefits, but it has other benefits as well. And so we're really trying to dissect out where that should go on your treatment plan. Methotrexate is the mainstay of treating autoimmune disease with regard to joint disease. And for years, because methotrexate has the small potential to cause a pneumonitis, which is a inflammation in the lung from the drug itself, many pulmonologists, lung specialists are very fearful to use methotrexate in a syndrome like this because they feel it'll exacerbate the underlying lung disease. One of my fellows, who I'll show you at the end of the talk, is looking at this question because are we fearful of methotrexate when it may in fact be the drug of choice for some? Azathioprine, or Imuran, is the drug we start with most often in my clinic when you have lung disease and muscle. It is better for lung than muscle, but sometimes it actually helps both. Cyclophosphamide or Cytoxan is a drug that I personally reserve for very severe lung disease or rapidly progressive lung disease because it has long-term side effects. I'm just going through the list, and I'm happy to drill down a little bit more in the open Q&A session. As I said, technically, I guess the session ends at 8. I will stay as long as you'd like me to within reason, I think till 8:30, and we can talk individually about any of these drugs you have questions about. Cyclosporin, again, lower down on the list, but it's very good for skin. Can sometimes help muscle and lung. IVIG, excellent for skin, so dermatomyositis, the skin involvement in this disease, which I haven't shown you slides of, but this is the typical dermatomyositis. You've heard a lot about at this conference. IVIG seems to help both muscle and skin. There is some anecdotal evidence that it may help the lung, so we do use IVIG in lung disease. The data are not there yet, but we're hoping to be able to comb through that data a little more to give you more information. It's an expensive drug. It's an infusible drug right now. It can be given subcutaneously, but that's difficult to do, and because of the volume and the amount of that we need of the product in autoimmune diseases compared to, for example, somebody who has an immune deficiency, it's a little hard to give it not in the IV form, but we are also in a trial to try to figure out if we can do that, give it IV. Mycophenolate is also known as Cellcept. This is the generic term for Cellcept. Again, good drug for skin, good drug for lung, maybe works for muscle. We hope it does, but not always. Tacrolimus is a very good drug for lung. Rituximab, as you know, I'll just say it's probably one of the most disappointing trials in my career because I think we all had great hope. And honestly, as a practicing physician, rituximab can be an incredible adjunct to some. So it doesn't work for everybody, but in the trial, which is called the RIM trial, which those of you who are veterans to this conference have heard about, which is rituximab and myositis. It was a trial of 200 patients, which in myositis, that's like the cardiovascular trials that have 30,000 people, right? 200 myositis patients, that's a lot. And we were very much banking on this. What happened in that trial is that it was a placebo-controlled trial that crossed over, where the first set of patients received the drug, and then the second set of patients 8 weeks later received drug. So one got placebo, one got drug, and they crossed. And the reason it was just such a short run-in where there was only 8 weeks difference is because children were included in that protocol, and the FDA felt that any more than 2 months of having children not on drug in the trial would be unethical, which is fine. But what we realized in retrospect is that rituximab may take a long time to work. What I've learned, and people in this room have taught me, is that I need to be patient. So rituximab can take up to 3 months. It really usually takes about 3 months before I see the first little sign that it's helping. So I would give up. However, if it isn't working by that time, I don't know that I've seen a lot of people respond at 6 months or 9 months. It happens, but it's rare. So within the first 12 weeks, the problem was that we couldn't see a difference in the curves of the people that started drug first and people that started placebo first. So while 83% of people in the rituximab trial responded, it was not meeting its primary endpoint of seeing a difference in those two curves. So consequently, what is happening is that I'm having a harder and harder time fighting with insurance to get a drug that is not on label. So be prepared, I'm gonna fight more and hopefully do some more research to show that this is actually the drug of choice in some cases. In the antisynthetase syndrome, most of the time we reserve that for later. There is some question as to whether it could in fact exacerbate underlying lung disease. Some papers in the medical literature say that it actually can. Others say it reverses it and helps lung disease. So jury's still out on that. And then, oh, sorry about that. Wrong button. The final one on that slide is the antisynthetase, anti-TNF inhibitors, which is this one. These are products like etanercept, which is branded as Enbrel, Humira, adalimumab. Those are the rheumatoid arthritis drugs. So those of you who have dominant arthritis as the main part of your syndrome, the antisynthetase syndrome, may want to try that. Cautionary tale, in some instances, these are associated with the onset of myositis itself. So, right, yin yang, you try to balance the good with the bad. But I've had some success in patients with pretty brisk arthritis to use TNF inhibitors. Okay. So these numbers are almost too small for me to see from here, but what I'll tell you is that we have over 2,000 patients in our cohort, and when we drilled them down, we said, okay, what do people have when we look at the antisynthetase syndrome? So the vast majority of patients, I believe, I can see is JO1. So we have vast majority have JO1, then PL12, PL7, and very few people with EJ or OJ, and we don't test for those other rare antibodies on the slide, which was KS, HA, and ZO. What do we see? Well, compared to the rarer ones, PL7 and PL12, anti-JO1 in general seems to have less severe interstitial lung disease at the first visit, and when we follow it up over time. Likewise, if you compare, in our cohort, we have a fair number of African American patients. If you compare black patients, compared to black patients, white patients have less severe ILD. So for better or for worse, there's a racial predisposition that lung disease seems to be worse in the black population than the white population of those that have this rare syndrome. In contrast to interstitial lung disease, most of them, antisynthetase patients, have only mild weakness. So I think I can show you here. So that improves over time. So here's weakness and here's CPK. So your muscle enzymes go down and your weakness gets better. The vast majority of patients muscle improve over time with this syndrome. Lung can be a little bit more challenging. So I told you at the beginning that cancer is associated with an increased risk across myositis syndromes. but for reasons totally unclear now, if you look at a standard incidence rate of cancer, and that means let's compare cancer in our cohort across population standards. Let's look at the general population and say, is your risk for cancer more? And in fact, it really isn't. So there is no increased risk of cancer that we saw in the 1,000 patients that we studied. And also, good news, really, no increased risk of mortality. However, in interstitial lung disease, those of you who have more severe lung disease, that definitely tends to be the most morbidity, the most difficulty that we have in controlling symptoms. And many patients, as you know, progress to oxygen, but do reasonably well for years and years and years. And there are people in my own cohort who have shown me that even with the most severe looking CAT scans, things that I thought wouldn't reverse or would not be able to be treatable are treatable. And there are living proof of those examples decade and a half later, which is why I love what I do. These are actually some of the other therapeutic approaches, which I actually spoke on the last slide. So I know you guys like to talk, like to have questions, like to have a Q&A. Teresa said I could do only a Q&A, but I couldn't do that for you because this is my forum to be able to give you a little background about what this really rare syndrome means. And I just want to tell you all the people behind who do this. Myself, Tom Lloyd is the co-director of the center. He's a new MAB board, the Myositis Association board member this year. And Andy Mammon, who helped me start the clinic, is still my partner in crime, but he's at the NIH these days, so he's gone on to the NIH. We're hopefully expanding our cohorts to have 2 institutions talk to each other. Sonia Danoff has done a lot of the work in interstitial lung disease. She's our pulmonologist, and her protege, Chalonda Johnson, whom I am so proud to actually see this team. They see patients along with me, or Andy or Tom, or any of the other rheumatologists on the slide here, which is Maima Albeida, Julie Pack, and Eleni Tiniakou. Some of you have had the pleasure of seeing them. They are, I say this is like the age before beauty slide, right? We became very multicultural and like prettier, but so these are the old people. And I'm like eternally 36 years old, and I'm never changing this slide. So, just saying. And then in the middle here is Tae Chung, who is, he is neuromuscularly trained, but he's also a physical medicine rehabilitation specialist. And what I haven't talked about, and you've heard about it here, certainly Helene Alexanderson, my good friend and colleague from Sweden, has taught us what exercise does in these diseases. We went from sitting still and saying, don't move, don't touch those muscles, you'll hurt them, to saying, get up and go. And he teaches me that the prescription for exercise should not be ignored any more than a prescription for azathioprine. He shows me his little slide and says, you cannot ignore that any more than a drug. It's the same thing. And so I'm learning from him. And finally, Doris Leung, who actually is the sister of my research associate who's here this year with me. And many of you have met her at our table, Sherry Leung. Doris is a phenomenal neurologist who does all of our EMG work, much of our EMG work in the clinic, and she teaches me every day. And I just want to show you a bit about, the beauty of, these are really, really the people that make me look old. These are all the young people that come from all over the world to work with us in our center. Many of you may have seen some of these people who come to the clinic visits with me. These are postdoctoral fellows. These are our research coordinators. Currently, Will and Sherry are with us. And these are folks from Canada, from Barcelona, from Tehran, also from Spain, from the US, all over the world, from Peru, and from places as rare as the Midwest and Utah. So we see people all over and train young people who really want to know more about these diseases. So it's at my heart, my soul. I do this. I eat, live, and breathe myositis for you, for me. And with that, I will open it up for questions. You won't offend me if you want to eat breakfast in 10 minutes. It's okay. But those of you that want to stay, I'll stay. I believe I'm allowed to stay a little longer, according to Teresa. Yes, ma'am. So do we give my volunteer, do we give a mic? Can I do that? Yeah. If you don't want to walk, if we can walk it to them. I'll also try to repeat if you can hear. Oh, there's one right there. Sorry.
Okay. Thank you, Dr. Christopher.
Can you get her a mic then, too? Okay. Oh, she has one.
Go.
Go ahead. There. Oh, go ahead. Yeah, she stood up first.
Thank you. What a wonderful presentation.
Thank you.
My question is that you see 2,000 people in cohorts. We in Australia see very, very few. My question is, can you describe any other commonality other than the medical side, what you see as presentation, which is common to the majority of people?
So let me see if I have your question correct. So you're asking, do people present to physicians in the same way across the world, or is that, or no? Is that
No, I guess I'm asking, other than specifically related antibody yes, antibody no, ILD yes, ILD no, do they come to you with other commonalities that aren't measured by research?
Oh, sure.
Do you see common things between people? Because you see a lot of people.
Yes.
But we don't over where I'm from.
Sure.
And I'm interested to know that that leads into the question that says, what is common between all of us that started this wretched thing?
Yeah.
Thank you.
So, sure. Well, as I tell my patients always say, can you tell me why I got this? I said, when I can, I'll win the Nobel Prize, because honestly, it's really that difficult. So Fred Miller at the NIH has a large study called Myorisk, looking at everything from dust mites in your home to anything you might have been exposed to. I think what happens is, so I think I'll get to your answer. So people present commonly with weakness, sort of subtle, and or insidious cough or shortness of breath, and then have maybe some other features on the slide, so we start looking. So it's sort of an insidious presentation of usually one of those things that I showed you clinically. And then people say, why did I get this? I have had people tell me, as little girls, that I chased mosquito trucks, sprayer trucks. I was a first responder. I was chasing a pesticide. I grew up on a farm next to a Superfund. And to be honest, part of the problem is there's sort of there's bias where you look back and say, it must be that I grew up in X in Australia next to that toxic place. And in all honesty, it's hard to do. Environmental studies are so difficult to figure out what the commonality is. I'll tell you, people have tried to look for it for decades. That's the largest study, and I think it's closed out to start looking and combing that data. So I do know that a lot of data was collected to see if there's any commonality, but the reality is I don't think we have any answer yet today. I know, I would love to tell you, we think about it a lot. I will say, we've long had this supposition, sorry to make you stand so long, we've long had this supposition that it is like a two-hit theory. So cancer seems to be, in many people, the genetic predisposition and then a second hit. In autoimmunity, it seems to me to be similar in that there seems to be that you come to the earth or you somehow acquire some predisposition, but it appears many times it is genetic. These diseases, however, this particular one is almost never familial. Lupus is, rheumatoid arthritis, family, generation after generation. For reasons unclear, we do not see many patients. There are definitely some I've seen that have some myositis link, but I've never been able to see two people in a family, never, that have the antisynthetase syndrome. So it tells you it's not completely genetic. But in other myositis syndromes we've seen, there's something called an HLA, which is a human leukocyte antigen. This is your background of what makes you you. We've seen incredible odds ratio saying it's not chance alone that you carry that background and you got this disease. So we do see, and like for example, in statin, cholesterol-lowering drug induced or associated myopathy, which Andy Mammon and myself first described, we saw an enormous predilection for one particular genetic component, right? And we saw that actually across both Caucasians and African Americans, even more so probably in African Americans, but we had fewer people in that group. So that didn't even seem to be a racial bias, where we definitely see some racial trends, which I showed you here. Can't tell you. We've thought a lot about it. With rare diseases, it is so hard. But people will do the mental gymnastics to say, could it have been this? Maybe it's what I ate. Maybe I think you'll drive yourself crazy. But we collect that information, but I've never been able to conclusively tell you something unites everybody. Susan.
Yeah, thank you for all those slides, particularly the ones on the medications. And you showed, indicated a few of them for skin disease. And you said IVIG has been pretty good for if the skin is getting worse. How would you decide, or we decide if if the skin is getting worse, the prednisone or Imuran should be increased versus going to the IVIG or the rituximab?
Sure. So what's the algorithm for deciding? Again, I'm going to tell you this is completely anecdotal. Let me also just tell you there's a large international effort, which I'm fortunate to help be a leader in that effort, called STAMP, which is Standardizing Treatment Approaches to Myositis, using expert opinion. So asking people that see this, which, as you know, right, the board that you'll see in a few minutes, which I've been fortunate to be a member of in the past, there are very few of us really in the world that study these diseases. So we're trying to figure out, okay, what do you do and why do you do that? Does that work? Or doing randomized controlled trials of medicines we use every day. Other than that, I'm going to just tell you this is my own opinion. How I decide to escalate drug, in general, if you don't, I use methotrexate for skin. If you have lung disease, sometimes we don't start there. We'll start with mycophenolate or Celcept. What I try to do is go to the highest level without being toxic of the steroid-sparing drug aside from prednisone. We always start with prednisone, for better or for worse. Prednisone, lowering that prednisone. If I can't lower your prednisone, I start another drug. Most people, in adults, I generally start, if you see me as a new patient, start prednisone along with a second-line drug, because it's really unusual to be able to treat this disease with prednisone alone. It really is. In children, yes. In adults, I just haven't seen it. And I feel like you get stuck on prednisone. You have glaucoma, you have high blood pressure, if everything, thin skin, all the things that happen with prednisone. So maximize the second-line drug. To be honest, it's those that we've used longer, that are cheaper. You have to prove, for better for worse, to most insurance companies that you've tried and failed, which makes me crazy. Sometimes you want to just go to a very high-level drug because the person's sicker, and you have to fail drug. This is the paradigm that is currently medical management. So you have to fail first-line drugs, those things like Imuran or azathioprine, methotrexate. Mycophenolate's a little more expensive, so that's considered maybe second tier. And once you have not had an adequate response to that after, say, 3 months, then you can start to petition for things like IVIG. IVIG, which I'm first to tell you, I think the drug is great. People have asked. It's not really a drug. It's a blood product. It's an immunomodulator. It doesn't suppress the immune system. If you ask people in a survey what drugs, what things help them the most, the first that people say is prednisone. The second is IVIG. It's expensive, and it's a blood product. And so for many reasons, you don't go there first most of the time. You graduate to that. So using IVIG would be something I would use second or third line when I failed other product, or a person is an extremis, where it is something where they're very, very sick quickly. I can sometimes get it that way by either hospitalizing someone or petitioning the insurance company. But that's hard. So you graduate over time. The other thing I've learned is that this disease is somewhat slow to respond in some, but if you're patient and watch it, it really does respond most of the time. There are always cases that befuddle me, and no matter what I try, it really is a really tough disease. There are people in this room that know, that have seen me, that I've battled, together with them, one after the other, and for strange reasons, one drug helps and the other doesn't at all. So you're an individual, and just what worked for you might not even work for your neighbor sitting at your table at breakfast. So we really don't know. A patient said to me recently, "What do you just throw darts at a board?" And I was like, "Kinda." Like a board that's well versed in experience of 10 years, and I try to put the rims and say that would probably be right. Where I'd love to go is to take that dartboard down and have a precision medicine approach, where you walk through my door and I say, "Oh, Mrs. Smith, let's just look at your genetic background. Let's look at all of these factors. You're going to be a mycophenolate responder. Wouldn't that be glorious?" That's where I hope that medicine will go in the future, and we're trying that. I have very bright young people, fellows, who are thinking just like that. Looking, and many of you know in my clinic, I have taken your blood, and many of you are frozen all through my freezers. Our freezers in the lab have contained you forever. We take those samples, we think about those, and we think about what that will do to help us try to have a precision approach. I always like more, and I have a very good person. I don't know where in Australia, but I have a wonderful colleague in Australia I'll tell you about. Yeah. I don't know. There's hands I can't see. Please tell me who was first.
Hi, I agree with IVIG. IVIG is heaven sent, and prednisone is from the devil. But
I'll quote you.
yes, my question, I have a two-part question. One is about the CPK. When I was diagnosed, it was 13,000, and now it's normal, but I still have up and downs, the same flare-up, the same muscle weakness as the beginning, and it doesn't rise. And for some rheumatologists, they live off that blood marker, and I had to change rheumatologist because he's telling me your CPK is normal, so you're okay. I'm like, but I can't even walk to you. Something's wrong.
Yes.
So
that's a fantastic question. So she's saying, why, if I presented with this syndrome with very high CPK, so if I think you guys are experts, but in general, a CPK is the same thing as a CK, that on most labs are about 250 or lower. Some it's a little bit lower, some a little bit higher. So say an average of 250. So 13,000 is nowhere near normal. So then it lowers, and then she's telling us she's weak, but her CK is normal. That is a conundrum that I'm not entirely sure, but it seems to be, I think, the amount of cell death that occurs, how much necrosis you have in your muscles. So if you originally present it to your doctor, and those cells look like the bottom slide a little, like lots of necrosis, they were dying, they were regenerating, people present this way, and then that all slows down. But you can still have inflammation and your CK can be normal. And who taught me that? Was children. So kids, half of the time, about 40% of the time, I'm not a pediatrician or a pediatric rheumatologist, but I think I quote my colleagues in pediatrics correctly, when they taught me that 40% of their patients, despite being weak, don't have high CKs. So a CK is not everything. This goes in both directions. So I think I can stay. So CKs that normalize and you still feel weak, I recommend an MRI of your muscle. That actually sometimes can help to say, there's residual fluid in there, there's edema, inflammation. Edema is water, fluid. So we're swelling. So we're thinking that the muscle looks abnormal. And I recently had a patient teach me that very thing in the hospital. He was hospitalized, not this, but a myositis syndrome, unfortunately related to cancer. He actually did quite well. And he said, I'm having a hard time walking. I said, your CK is 43. And I do this myself. I said, well, we must have treated this thing. We did an MRI and every muscle lit up. I said, we're not treating this thing the way I think. So I will say that there's often a difference. So an MRI can help, a muscle MRI done the right way, can really help us see whether or not there's residual inflammation in there. So I think probably that answer is whether or not there's a lot of cell death. That's really what seems to cause the high numbers. Likewise, I'm going to tell you, and I hope that helps you, don't have a doctor tell you feel better when you don't feel better. Other people tell me the same thing, that they came in, their doctor said, I treat you with prednisone, your CK is normal, the good news is you're better. And what I learned is that you can normalize the CK quite nicely, actually, with prednisone, and the person is not getting better. So CK will lower with prednisone. Sometimes, actually, that follows the clinical course, and it is what you need. And sometimes it just lowers the number, and you are not touching that inflammation, and you need a second-line drug. So I do think CK is a nice barometer for some people, and some people will call me and say, I know that my CK is 400, and darn, they're pretty close. They can predict by the way they feel how their CK looks. Most people can't. Many people cannot do that. So I go by symptoms and I go by the patient. And if I'm really confused when there is that problem where you're looking weaker, you can't stand off my examining table, can't get off my chair, people that see me know I get them off a low-seated stool at 6 inches. If you can't stand off that chair and you could last time, there's something wrong. And then we start investigating what that is. Every once in a while we'll do an EMG again. I try not to do that because that's not the most pleasant thing. But sometimes we have to repeat that. So I hope that helps. Likewise, a high CK, some of you that have a CK that maybe is 500 and you feel great, many of you in this room know I will watch that. I'll tolerate that. I'll ask how you feel. People get nervous. Home physicians get nervous who don't see this a lot. I mean, 500 for me, after seeing 13, 16, 100,000, we're okay in some cases. In some people, 500, they're so weak they can't lift their head. So I go by the patient and the CK in combination and try not to necessarily link one to the other all the time.
Hi, doctor. Thank you.
You're welcome.
I'm Dr. Mammon, one of Dr. Mammon's patients.
Lucky you.
Yes, he saved my life. There's the head itch that nothing was referred to. I just had an IVIG treatment, and that itch just will not go away.
Scalp.
Yes.
Yeah.
only on the scalp, basically, primarily, and then sometimes my ears or whatever, but primarily the itch, if you can recommend anything. And the other thing was that even after, how long does it take that IVIG to kick in, although I had only half the dosage because of the aseptic
meningitis, yeah. All right, so that's a lot of questions in one. I'll try to say. So the first is that what do you do with a head itch? You have IVIG, you've had good treatments. I mean, sometimes, so not knowing your exact clinical story, I'll add another agent to the IVIG and try to see if we can get coverage with something else like mycophenolate. Can sometimes be very good for skin. If you haven't tried, I'm sure you have, but if you haven't tried betamethasone shampoo, which is Luxique, it's like a foamy shampoo that sits on your scalp. Having said that, I was talking to some of my patients even at this clinic, and they're like, my scalp always itches. So I would try a specific steroid shampoo, betamethasone or Luxique, Luxiq shampoo. Some people say it works like a miracle. Some people say it doesn't touch their itch. Itch is a very frustrating part of this disease. We actually tried to look at itch receptors in the skin because lupus looks a whole lot like this disease, and yet it doesn't itch. Lupus does not itch. Dermatomyositis itches. So there's something different. It's not just the immune response. There's an itch receptor in the skin that's somehow activated. The other thing I do, quite honestly, is just try to use anti-itch medicines like hydroxyzine. That is it was branded under an old drug called Atarax. They're extremely sedating. So antihistamines can help, but they put you to sleep. But so trying combination second-line drug with the IVIG, trying a local betamethasone or other steroid shampoo, and I mean, those are the two probably the most common things we do. And then it's not treating the itch, but at least maybe putting you to sleep so you're not scratching your scalp off, is doing something like hydroxyzine. You need me? So the announcement is, bye to those of you in the web world. We're not streaming anymore. I will stay here for a few more questions. If you want to eat, you must be in the room by 8:30. And if any of you want to go now to eat, I will not be offended. And those of you who want to stay for further questions, I'll stay for another 20 minutes. I can.
Hi,
Please.
Dr. Stein. Thank you very much for your presentation.
My
It was really
pleasure.
great. I have 3 questions, very short, 2 first ones.
Sure.
Vitamin D, I take a supplement. How often should you be tested to get it, and does it stay in your body?
Yes, great question. So can you keep vitamin D in your body? It seems no for a lot of people. I would say that 85% of my patients, that's my guess, are vitamin D deficient. So I'm not sure if this disease makes you vitamin D deficient or just the world is vitamin D deficient. I test every 12 weeks. If your vitamin D is under 30, you should take 50,000 units of something called ergocalciferol, ERGOCalciferol, 50,000 units once weekly. It's a high potency vitamin D, and after 12 weeks, so 3 months, check it again. Okay. If it's normal and you're up where you need to be, I recommend 2,000 international units a day of vitamin D, and then you check it again in 12 weeks. So on average, people cannot get vitamin D from their diet alone. We get it up there, we feel great, we stop the treatment, and then 2 months, 3 months later, it's back down.
Okay.
You can take, thank you, it's like, you're like my prompt. I was just gonna say, but you can take too much. I've seen somebody's vitamin D level like 250. You wanna aim for maybe about 50. So yes, you absolutely can be hypervitamin D, so do not do that. Do not take it until it's so high that you're toxic. Yes, you can take, you can do too much of almost anything, but yes.
Okay, the second question, I get a little confused with anti-Jo1 and Jo1. So anti-Jo1 means no JO1 antibodies?
No, sorry. So that's a great question. Anti means against. So anti-Jo1 is the antibody that targets Jo1. Jo1, by the way, was named for a patient. So JO were the first 2 initials of that patient that they first described. That's histidyl tRNA synthetase. That did not roll right off the tongue. So that's so the amino acid is histidine, that it's targeting that enzyme. So anti-Jo1 just says it's against Jo1, and Jo1 is that enzyme in that little circle I showed you. Anti means really antibody. It's not it's not no Jo1.
Okay.
And when often we say, oh, are you Jo1 positive? It's a slang or a short for anti-Jo1. Just hard to say anti-Jo1.
I was a little confused.
Sorry. Yeah.
That's okay. And the last question is, what determines if one will get ILD or not, and is ILD connected to a certain antibody?
Yeah, so interstitial lung disease, ILD, is connected to all the antibodies, the antisynthetase syndrome that I showed you. If you have the rarer ones, PL12, PL7, that I showed you in the list, those people almost uniformly get some form of lung disease, often more severe. JO1, we do see lung disease. I sort of showed you the number. So of those people that have JO1, 70% probably have some form of lung disease. Some of it's asymptomatic or completely, and it may remain that way their entire lives. But all of the synthetases have a predilection for the lung. Those of you that don't have lung involvement, I hate to say it's always this way, but it seems that some people just have muscle or just really have a lot of skin involvement or joint and don't have lung from the beginning, and 3 years later they don't have lung. I don't think I can think of many, maybe of any, examples of getting lung disease 7 years, 10 years into the course. So I'd say that.
I've presented with all three, skin,
It's common.
muscle, and ILD. However, I was negative for all the antibodies. So I'm not sure how or where it came from, but I think
When you say all of the antibodies, we could talk.
the panel was in like 2004. I was originally diagnosed, so I don't think the panel was.
You need to be updated,
Yeah.
because those other, so first of all, we have better detection, and second of
Right.
all, there's mimics that I showed you on the slide. that
Right,
Not
now that I
everything
know of
doesn't
those.
look like a duck, right? And those antibodies are more rare, but they're important for you to know if you have them.
Thank you
Yep,
very
I
much.
bet you have one, you just didn't
Yeah,
know at
don't
the
know
time.
which one. Yep,
Yeah,
thank
we
you.
were catching up. Thank you. These are great questions. Please, I will never stop you from breakfast, never. My fellows that rotate with me know that the one thing we need to do is eat. I'm get hangry. I'm hungry angry. I totally get it.
Hi, we love you.
Thank you.
If you have PM and you have the anti-JO1, can you ever get IBM? Or have you ever seen JO1 and IBM?
Have I ever seen it?
I mean, it's,
So her question is, can you morph into one and the other? I will say that if I've seen it, I don't remember it. It's
Okay.
extremely rare. I do think that some people, so we've always said that IBM is a refractory PM, it's just that, oh, you've always had it. I do think there is a small population that starts off as what looks like polymyositis, may respond to steroids, certainly looks that way, and years later, they look just like IBM. So I do think it's not a perfect syndrome, a perfect classification, but I don't know that that's something I can think I've seen in my career.
yeah. Well, my husband has a PM with the JO1.
Yes.
Never had a muscle biopsy or anything. Can we be truly sure that he has PM?